Dr. Roger Henderson, and I'm one of the GP Notebook Study Group presenters. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, we'll be discussing adhesive capsulitis, more often known as a frozen shoulder, and a condition which is frequently underdiagnosed in its early stages, and patients are often told they've got non-specific shoulder pain, rotator cuff disease or impingement, and by the time the correct diagnosis is made, they may already be well into the fibrotic phase of the condition. And this delay matters because early recognition can significantly alter symptom burden, functional limitation, and overall recovery time. So, adhesive capsulitis is probably best defined as a disorder of the glenohumeral joint that's characterized by progressive pain and a global restriction of both active and passive range of motion. And that restriction is mechanical and not simply pain limited. And it reflects structural changes within the joint capsule itself. External rotation is typically both the earliest and the most severely affected motion, followed by abduction, internal rotation, and finally flexion. Now, as we all probably know, the population most affected tends to be middle-aged adults, usually between the ages of 40 and 60, and there's a very modest female predominance, with the condition more often affecting the non-dominant shoulder, although bilateral disease isn't uncommon, particularly among patients with diabetes. And diabetes is the most consistently identified risk factor here, with prevalence rates of adhesive capsulitis up to 5 times higher than in the general population. Thyroid disorders, particularly hypothyroidism, are also strongly associated, and patients with these comorbidities often experience more severe disease and slower recovery. Now, from an etiological standpoint, adhesive capsulitis is traditionally divided into primary and secondary forms. Primary adhesive capsulitis is idiopathic, and little is known about what precipitates the loss of motion and pain in these patients, and there's no identifiable inciting trauma, surgery, or immobilization here. And these patients often describe a spontaneous onset of shoulder pain that then gradually progresses to stiffness. The frequent association with endocrine and metabolic disorders does suggest a systemic predisposition, possibly related to chronic low-grade inflammation, immune dysregulation, or even altered collagen metabolism. Secondary adhesive capsulitis, on the other hand, develops in the setting of a known precipitating factor, and these may include shoulder trauma, such as fractures or soft tissue injuries, post-operative states following shoulder or thoracic surgery, or prolonged immobilization for any reason. And in these cases, reduced motion appears to initiate capsular tightening, which then progresses into a self-sustaining fibrotic process. And importantly, once that fibrosis is established, restoring motion becomes increasingly difficult regardless of the original secondary trigger. Now, epidemiologically, adhesive capsulitis affects approximately 2 to even 5% of the general population at some time. And whilst this may seem relatively modest, its functional impact is disproportionate given the prolonged disease course and the central role of our shoulder mobility in daily activities. Among patients with diabetes, as discussed before, outcomes are consistently worse with longer disease duration, higher levels of HbA1c, and insulin dependence. These are all associated with more refractory disease, and this may reflect the cumulative effects of hyperglycemia on the integrity of connective tissue. If we look at pathophysiology, then adhesive capsulitis represents a continuum from inflammation up to fibrosis. So in the early stages, inflammatory mediators within the synovium and joint capsule lead to pain and vascular proliferation. Cytokines, such as interleukins and transforming growth factor beta, are thought to promote fibroblast activation and collagen deposition. And over time, this inflammatory environment then slowly gives way to dense fibrosis, capsular thickening, and contracture. And the rotator interval plays a central role in this process. So thickening of the coracohumeral ligament and fibrosis within the rotor interval contribute significantly to loss of external rotation. The axillary pouch also becomes contracted, reducing overall joint volume. And these changes aren't subtle. Studies have demonstrated measurable reductions in capsular capacity, which do correlate with clinical stiffness. If we go histologically now, early disease shows synovial hyperplasia, increased vascularity, and inflammatory cell infiltration. And as the disease progresses, fibroblasts proliferate, the collagen becomes densely packed, and the capsule loses its normal elasticity. And arthroscopic findings align with these observations, typically revealing a thickened synovium, fibrotic adhesions, obliteration of normal capsular recesses, and restricted joint movement even under anesthesia. Now, clinically, adhesive capsulitis is often described as progressing through 3 overlapping phases, although it's very important to note that these phases are not always distinct. And these are typically known as the freezing, frozen, and thawing phases. So, the freezing phase is dominated by pain, and patients experience a gradual onset of deep, aching shoulder pain that worsens with movement and then often disrupts their sleep. Their range of motion also begins to decline, but pain is the primary limiting factor here, and this phase may last anywhere from 2 to 9 months. And this is followed by the frozen phase, during which the pain may stabilize or even improve, but it's stiffness that then becomes the dominant complaint. And at this stage, capsular fibrosis is well established. Patients have difficulty with nearly all shoulder movements, particularly tasks requiring external rotation or overhead reach, and their functional impairment is often severe, with this phase persisting for several months to over a year. Finally, the thawing phase is characterized by a slow but gradual improvement in the range of motion and a slow continued reduction in pain. However, recovery during this thawing phase can be slow and incomplete. So while many patients can eventually regain near normal function, others are left with residual stiffness, particularly in external rotation. So the entire disease course can span from 1 to 3 years, and in some cases, in my experience, even longer. Now, history taking is critical here in recognizing adhesive capsulitis, and patients will often describe an insidious onset without any history of trauma that's followed by slow, progressive stiffness. And the pain may initially be intermittent, but then becomes more constant over time, with sleep disturbance becoming common, and patients frequently reporting difficulty with dressing, grooming, or reaching behind their back. Importantly, this pain often precedes the stiffness, and this can help distinguish adhesive capsulitis from other causes of shoulder dysfunction. On physical examination of these patients, the defining feature is a marked limitation in both the active and passive range of motion across multiple planes. An external rotation is typically the most restricted movement, and this finding is particularly helpful diagnostically. There may be pain at the limitations of motion, which signifies capsular tightness, synovitis, and irritation. If you do strength testing, this may appear reduced, but true weakness is actually quite uncommon, and this usually reflects pain inhibition rather than any muscle pathology. Neurological examination is virtually always normal, and this helps exclude cervical radiculopathy or peripheral nerve injuries. And don't forget, the coracoid pain test is a highly sensitive and specific clinical examination finding here for adhesive capsulitis, where the pain is elicited by direct pressure on the coracoid. So the diagnosis of adhesive capsulitis is a clinical one, and there is no single diagnostic test for it. And routine laboratory studies aren't indicated unless you've got concern about an underlying systemic condition. So plain radiographs, AP, lateral and axillary views of the glenohumeral joint are the preferred initial test if you want to do one, and although these are often normal, they can be helpful in excluding osteoarthritis, fractures or other structural abnormalities. You might also consider ultrasound as an initial imaging study here, as it does have the advantage of allowing provocative manoeuvres to assess impingement. MRI scans without intravenous contrast is usually appropriate when adhesive capsulitis is suspected and the initial radiographs are normal or inconclusive. And MRIs may demonstrate capsular thickening, synovitis, and loss of axillary pouch volume. But this imaging should always be viewed as supportive rather than diagnostic. MR and CT arthrograms, however, are not routinely recommended when evaluating for adhesive capsulitis due to conflicting results of efficacy studies. Now, one useful clinical maneuver here is the use of diagnostic injections. Now, when local anaesthetic is injected into the subacromial space or the glenohumeral joint, the pain may decrease, but the range of motion remains limited in adhesive capsulitis, and this finding helps differentiate it from conditions such as subacromial bursitis or rotator cuff tendinopathy, where the pain relief often leads to significantly improved mobility. The differential diagnosis here includes things like rotator cuff tears, subacromial impingement syndrome, glenohumeral osteoarthritis, inflammatory arthropathies, and cervical spine pathology. But what distinguishes adhesive capsulitis is the global restriction of passive motion plus the characteristic pattern of stiffness. So looking at management now, this is largely conservative and should always be tailored to the stage of the disease. So a stepwise approach, beginning with non-invasive treatment, then gives way to invasive interventions if early treatment options prove to be ineffective. So, patients should always be advised to avoid exacerbating activities in order to interrupt the cycle of ongoing inflammation, and this may necessitate significant time off work or away from their preferred leisure activities. And physical therapy is the cornerstone of treatment here, with an emphasis on gentle, progressive range of motion exercises. Don't forget that aggressive stretching in the early inflammatory phase may actually exacerbate pain and reduce compliance. So your timing and technique are critical. Don't forget too that a useful exercise here that can be performed by the patient in their own home is known as the sleeper stretch, and this works on improving internal rotation. So, with the patient lying on their bed on their side, with the affected shoulder down against the mattress, the elbow is flexed 90 degrees, and the unaffected arm then slowly pushes it towards the bed. Now, corticosteroid injections are most effective in the early stages if you're going to use them, as these do provide a concentrated local treatment of the inflammatory process involved in adhesive capsulitis. And they also provide the added benefit of pain relief, especially with active and passive range of motion early in the disease course, which is obviously vital in allowing the patient to participate in physiotherapy. And I consider them in patients who present with pain despite initial physiotherapy and the use of non-steroidal anti-inflammatory drugs. There's some limited evidence that oral corticosteroids may also offer early pain relief here, but the benefits are short-term and may not last beyond 6 weeks. Now, I mentioned non-steroidals, and these are commonly used for symptomatic relief, although their impact on long-term outcomes is limited. Patient education is essential, particularly regarding the prolonged and often self-limiting nature of this condition, and setting realistic expectations can significantly improve both patient satisfaction and adherence. Now, for patients who fail to improve with all conservative treatments, then surgical options may be considered. Manipulation under anesthesia and arthroscopic capsular release are now the most common interventions, and both can be effective, but they do carry risks, including fractures, tendon injuries, and post-operative pain. So a careful patient selection and structured post-operative rehabilitation are essential to achieving good outcomes. The complications of a frozen shoulder may arise from the prolonged immobility associated with it, including muscle atrophy, altered biomechanics, and secondary shoulder pathology. And surgical complications, whilst uncommon, can be significant, and so should be discussed thoroughly with patients. Fortunately for all of us, the prognosis for adhesive capsulitis is generally favourable. Now, although the disease course can be very frustrating for our patients, the vast majority do make a full recovery, usually within 18 to 24 months, although a small minority continue to experience persistent stiffness or discomfort. Patients with diabetes or thyroid disease do tend to have longer disease courses and less complete recovery. And a previous history of adhesive capsulitis has now been shown to be a risk factor for occurrence in the contralateral shoulder. So, just to sum this up now, adhesive capsulitis is a multifactorial condition involving inflammation, fibrosis, and altered biomechanics. Its early recognition, accurate diagnosis, and phase-appropriate management are the key to minimizing disability, and, given its strong association with systemic disease, adhesive capsulitis should always prompt us to consider the patient's broader metabolic and endocrine health. So that's a quick overview of frozen shoulder, and I do hope you found the podcast helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch with us via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. We really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.